Managing Optic Pit, the right stuff. This video presents 15 years of experience with the treatment of optic pit maculopathy by vitrectomy. Vitrectomy with gas is performed. Improvement in the status of the retina is achieved after many months. Another example illustrates how difficult it is to detach posterior hyaloid in these eyes. After vitrectomy, laser treatment at the temporal side of the optic nerve is applied, and fluid-air exchange follows. Improvement is achieved after 15 months. Laser treatment may also be performed before vitrectomy. Sometimes ILM peeling improves the quality of posterior hyaloid detachment. ILM peeling is safe at the temporal side of the optic nerve whilst avoiding the centre of the macula. In eyes with outer lamellar macular hole appearance, ILM peeling and laser at the temporal side of the optic nerve may also be safely performed. Since 2009, we began to cover the optic pit with an inverted ILM flap. Laser treatment was added. Fluid-air exchange follows. Our initial results were comparable with other methods. Recently, the European Vitreoretinal Society Optic Pit study showed no advantage of this technique when compared to other modifications of vitrectomy. The study also showed that any modification of vitrectomy is better than observation or laser only. The similar effectiveness of 3 modifications of vitrectomy may suggest that there is no best method. Recently, Jane and Johnson described the anatomic features of an optic pit and the mechanism of fluid migration. We can learn a lot from our failures. Here you see reoperation of an eye after 4 years of initially successful treatment using an inverted ILM flap to cover the optic pit. During repeated surgery, we can see that the ILM initially covering the optic pit is present again in its original position. The latest modification of the technique is to stuff the pit by carefully introducing the ILM into the pit cave. Laser treatment and fluid-air exchange is performed. Complete recovery of maculopathy is observed during the first control after 7 days. Another example shows that the inverted ILM flap technique did not allow maculopathy to heal even after a second attempt. During a third surgery, ILM was also gently stuffed into the optic pit. Almost complete healing of maculopathy was observed after 7 days. Conclusion. Stuffing an optic pit with ILM seems to be a logical and successful modification to vitrectomy for the treatment of optic pit maculopathy.